Just to start off, I wanted to introduce myself and those of us here. I'm Matt Mikhail, one of the breast imaging specialists working with ECHN, mainly over at the Women's Center for Wellness in South Windsor and at the Manchester Memorial Hospital. And I'm joined tonight by Kristen, one of our fantastic mammographers and the manager of the Women's Center, and Stacy, who's our team lead and one of the sonographers over there as well. So really wanted to make this kind of an informal and hopefully useful just kind of way to familiarize people with kind of what kind of breast imaging and particular screening breast imaging is about, why it is that we do it. And there's a lot of different language that goes into the reports that everyone sees. And so it's not something that is all that intuitive to a lot of doctors, let alone patients. And so I feel like it's useful to kind of be able to talk about some of that and give people a chance to ask questions about what it is that you're reading when you get a screening mammogram or ultrasound. And so just to kind of go over more or less what we're going to talk about, we hope to kind of touch on what is breast cancer screening, why do we do it, what are the ways to have screening, like types of screening exams that can be done to screen for breast cancer, give a little bit of insight both through Kristen and Stacy about kind of what to expect when you're there for the exams. Then kind of a little bit more from my perspective, what radiologists are looking for on the studies that you have done. What do the results and the reports that you get back look like? And we'll have some examples of those. And then why, as part of what radiologists are looking for, why people might end up being, called back or asked to come back for other imaging and what types of imaging and things like that. So just kind of hoping to touch on a bunch of those things, but to set the stage, I just wanted to start with kind of why is it that we care about this? How big is this problem? And breast cancer is unfortunately one of the more common cancers in the U.S. Over the course of their lives, 1 in 8 women will at some point develop breast cancer. And each year, so for instance, it's projected that this year in the US, there'll be about 350,000 cases of breast cancer that are diagnosed. So it's a significant number. And for reasons that we're not entirely clear of, that number seems to be kind of increasing over the past few years. There are some statistics from the American Cancer Society saying it's increasing about 0.5% a year. So there's definitely still a lot of research and work that needs to go into kind of understanding some of those things. But it clearly is something that affects a lot of people, and it's and something that we can do things about. So just to kind of give a brief overview of like the anatomy of what we're talking about. We have here kind of just an image of pictorial image, anatomic image of a breast. We can see kind of this is like looking straight forward, and this is kind of a cross section on the right. And primarily there are, some say, 3 or 4 components to breast tissue. Kind of the main functional components, and the purpose of the breast is to develop breast milk for breastfeeding. And the component of the breast that actually produces that, those are called the lobules. And these are little areas here that you can see that kind of produce the milk. And then in order for those to be transported to the nipple, then it uses ducts to get there. So connecting these lobules towards the kind of the nipple are these ducts. And so either one of those components of the breast can develop breast cancer, and those are different types of breast cancer that can develop. The most common arises from the ducts, those transporting units to get there. And less common is within the lobules themselves, but there's a lot of other support structure within the breast as well. In particular, in most patients, a pretty substantial portion of the breast is actually fatty tissue. And that's actually the basis for the way that we can see things in the breast on an X-ray or a mammogram is by using the fat against the breast tissue, and we can see kind of the differences between those. There's also a lot of connective tissue within breast, and that helps it to kind of form the organization and the units that need to be there in order for it to function. And so those are kind of altogether the four main parts of the breast. And then here on the left, you can see just a little pictorial about how it is that fluid and different things are drained out of the breast into the rest of the body. And that's through what we call lymph nodes, which are part of a system that helps kind of filter fluid and things from different body parts. And you can see here that there are certain types of lymph nodes that specifically drain the breast. And those are in the left armpit, or here you can see an armpit. And this is kind of along the chest wall. And so when one has cancer, typically that's the way that cancer tends to spread, is towards those body parts. So part of our imaging is also often looking at those parts of the breast as well, for anything that may be a secondary sign that something's going on. So let's talk about screening itself. So here we have different recommendations from different cancer societies and organizations in the US as far as what the current thoughts and recommendations are for mammography. And I think we're pretty fortunate in the realm of breast cancer that it's one of the most meticulously studied screening programs that has existed, the most history kind of program for breast cancer or for cancer screening in the US. So there's very specific rules in place for how we do it, and it's done in a very standardized way across the country. And we have certain federal legislation that helps to ensure that across the country. And so that's part of what's made it so successful, is it's really been an organized effort on the federal level. What that means is that we can also get specific statistics about, what breast cancer screening and mammograms do. So here at the top, this top row, we can see that this is actually the screening recommendation for the American College of Radiology, which essentially all radiologists follow. And that's to suggest annual screening mammograms beginning at age 40, and by annual meaning every single year. There's not a definite cutoff on the end date, but it basically has to do with, in general, health, and if someone's healthy, they can get mammograms going into their 90s plus. But here, for example, and for a reference, they used 84. So for those women who are getting screened annually starting at age 40, we know that there's about a 40% reduction in breast cancer deaths, or essentially the risk of dying from breast cancer is reduced by 40% just screening every year, and by that early detection itself. And that's estimated to be about 1,000 per 100,000 women screened. So it's pretty significant. Below that, we can see here, this is just recommendations from a different organization. This is the American Cancer Society. This starts a little bit later and then switches from annually to every other year at age 55. And so there we can see that just by changing those things, that benefit kind of drops by about 10%. So pretty significant reduction. And the bottom here is the United States Preventative Task Force recommendations that were present up until, I think they're still the official recommendations. And there you can see it's every other year starting at age 50. And that basically halves the benefit of mammography. So really, us here in our profession, and in particular radiologists, are very adamant that we feel like the best benefit is really annual mammography beginning when you're 40. And that's really been studied pretty extensively, but there are always ongoing kind of studies as far as new ways to screen. And as we mentioned kind of the rates of breast cancer are changing and those who get it at different ages are changing, then that also can evolve over time. But that's kind of our current best understanding. And so the kind of most basic type of breast cancer screening and kind of what most people are probably familiar with is either the breast self-exam or the clinical breast exam. The breast self-exam is essentially you yourself kind of knowing your body and checking on a somewhat routine basis whether there's anything that you notice that is abnormal for you. And of course, that's an important thing in general for just kind of being aware of one's body and being able to kind of key anyone in on something that you're noticing first before anyone else. The clinical breast exam is kind of the same idea, but done more kind of systematically by a like your primary care provider or your gynecologist or someone who kind of is trained in just doing a more systematic exam of the breasts and being able to kind of discern the same types of things. If they notice something that could be a lump, then that's something that could key them in on getting earlier or more specific targeted imaging. But as far as all the research that we have thus far, neither of those things have been shown to actually have a statistical benefit in breast cancer detection. That said, it's still very important to be familiar with, your body, and if there is anything that you feel or notice, then that's an important thing still to let your provider know and see what further, if anything, needs to be done about it. But the gold standard in screening for breast cancer and what's really shown the best benefit has been mammography. And there are different ways to do that. It can be done in what's called 2D mammography, which is kind of another word for an X-ray of the breast, and they're done in certain standard views that we get. There are 2 standard views for each breast. And the more recent technique is what's called 3D mammography or tomosynthesis. And that basically takes a bunch of small little images at different angles using the same projections, the same types of images as the 2D mammogram, but it gives us more depth information so you can see different slices within the breast. And early research has shown that that's actually improved the how sensitive that mammograms are in most patients, as well as it prevents decreasing false positives for mammograms compared to 2D mammograms that we typically are seeing more conventionally. So that's mammogram, and that's the gold standard. Other newer modalities, newer ways of imaging are breast ultrasound, which is kind of like what you'll get. It uses sound waves to take a look at the breast, and it's like what one would get when they're pregnant to look at a baby or something like that. But it gives us the structure information and a good picture of the breast tissue. The benefits of that are that there's no radiation involved, but there are definitely some downsides to it. One of the main ones is that it's a manual process where someone is physically scanning in different ways along the breast to hopefully cover most of the breast tissue, but it's still dependent on who's scanning. And so based on the way that they're looking, things can look different. And so it's harder to compare from one type of ultrasound to another and from one person doing the ultrasound to another. Separately, it picks up a lot of things that may not be breast cancer as well. And so that's what we call false positives. And that's a big problem in certain ways. In particular, that causes a lot of anxiety. What it means is that on a report, there'll be something that says there's something that needs any further imaging or that needs follow-up. And the vast majority of those things end up being normal or benign things. But then it causes more exams to need to be done, and it of course causes worry, and that's not something that we always want to avoid when we can. Breast MRI is another really much newer way of looking for breast cancer. It's kind of a little, also doesn't use radiation. It's more repeatable than ultrasound, but it's also a lot longer, more time consuming than ultrasound, more expensive, and it still has quite a few false positives. So it has certain specific indications, as we'll get into when we talk about high risk screening, but still hasn't really found a proper place in just kind of routine screening. So those are kind of all the types of screening that we have available to us to try to be able to find anything that would be worrisome or that would be breast cancer early, and be able to manage that kind of before it became any sort of issue. Questions about those types of breast cancer screening? Okay, great. So what I'm going to move on to now is I'm just going to turn it over to Kristen and Stacy. We're going to talk a little bit more about what to expect when you're there, either getting a mammogram or a breast ultrasound, and kind of be able to answer any questions related to that.
Perfect. Thank you, Dr. Mikhail. As you mentioned, my name is Kristen. I'm one of the mammographers here at the Women's Center for Wellness. So just to break down, if you come here for your screening mammogram, what to expect in the room. So what we do as techs is we have all of our patients fill out a mammo history sheet form. That's very important to go by. What we like to do is go over it with you in the room in case you have any questions or any concerns that we can go over. But the main things that we look for, have there been any changes over the last year since your last mammogram in regards to your own personal health? If you've ever been diagnosed with cancer, any surgeries in the breast area, biopsies done, and also very important, any family history. Last year, you may not have had a family history, but this year, unfortunately, maybe somebody was diagnosed in your family. Again, so these are all important things that we look for. Also, we ask that you fill out an area of any problems or concerns in the breast area. As Dr. Mikhail mentioned, there's some, it's important to do your own self breast exams because you would notice a change, probably more quickly than your doctor, because you know your own body if you're doing it frequently. So if you notice any lumps, any change in the skin, nipple discharge, pain, anything like that, we want to make sure that you speak up and let us know that at that time. So the other big thing that we do as mammotechs is we pull the prior imaging. So if you were with us last year, we like to take a look at the study from last year before we start the exam that day. And the reason for that is we like to make sure that our imaging is very similar to last year's, both in positioning and also with compression. So compression is something that if you've all had a mammogram, I'm sure that's what you think of when you think of a mammogram. It's not the most comfortable. It should never be painful. It's just more pressure than anything, I think is the best way to describe it. But I always let my patients know the entire time I'm with them, I check in on them, make sure they're okay, and that they can tolerate the compression, because we never want you in pain. We don't want you to never come back again because it was so uncomfortable. So please know that when you're having your mammogram, please speak up, because from a tech standpoint, if you're uncomfortable, we can stop and back you out of the machine and bring you in a different way. And sometimes that makes the world of a difference. So definitely speak up and let us know. But what we usually do, though, we want to make sure that we have similar compression to last year, and also the same amount of breast tissue in the image. That's very important. So sometimes we usually do 4 images for every patient, but sometimes the tech may have to do an extra one just to include a little more tissue. Because if last year the tech was able to get that, we just want to make sure we have similar images to submit to our radiologist to look at. And then once we do our imaging, we take a look at our pictures at the end, make sure we're happy with them. I do always let my patients know, right now, roughly it's about a week for routine mammogram results to be read, and that your ordering physician will get those results. And what the radiologist looks for, which Dr. Mikhail will go into detail about, but we just want to look at the imaging and make sure that they look very similar to last year. But if there's something that does look different, that's when you might be called back for some additional imaging as a diagnostic study. So the only other thing, which Stacy, I think, would be able to go into next is, and also Dr. Mikhail will go into too, is in regards to breast density. So that's something that ultrasound is the best study for, and depending on the report itself and what the doctor dictates as far as your breast density, that's when you might be coming in to see our ultrasonographers here. So I will pass it to Stacy.
Thank you. Hi, everybody. My name's Stacy. I'm one of the ultrasound techs here. So like Kristen quickly touched upon, in ultrasound, while we do dense breast screenings, we also do diagnostic ultrasounds as well. So a lot of times, more times than not, ultrasound is usually following the mammogram. If you are someone who falls in a dense category with your mammogram, you would be coming to us, and Dr. Mikhail will go into more detail about this, but basically, when you have a lot of that denser tissue, it can almost be like a snowstorm in the mammogram, trying to see through that dense tissue, and nodules, cysts, things like that can kind of camouflage within that denser tissue. Ultrasound can see through that dense tissue a bit better. So that's why an ultrasound could be recommended. Also, if something particular is seen on your mammogram, an ultrasound can be recommended either on its own or after a mammogram. Now, while mammogram gives you compression, which probably is what you all think of with the mammogram, like Kristen said, ultrasound just gets you a little goopy, but we do not squeeze you. So we're a little messy, but in the ultrasound, same as mammogram, we're going to go over your prior exams. If you've had ultrasounds in the past or things we've been following, we're going to want to look into that. And we're going to want to make sure, as the ultrasound tech, that we're using the same locations for anything that we have found in your breast in the past. We want to know if you have any concerns that day or recently, pain, anything you're feeling, things like that. We're also going to go over your history form that you filled out for the mammogram. While you're in the room, just position wise, you're just going to be lying on a stretcher. We might turn you a little bit side to side, but other than that, it's a pretty straightforward exam. There aren't many limitations or any type of, prep that you have to think about beforehand. And so basically, when it comes to a screening ultrasound, like Kristen also touched upon, it'll take about a week to receive results from your doctor. When it comes to a diagnostic ultrasound, you will receive those results before you leave that day.
The whole idea of being recalled from a screening exam. And so like any test, the purpose of a screening exam is to pick up as many people as possible who may have something that need to be further evaluated. But a good screening test is a test where you pick up more than those people who have something that more than those people who have breast cancer, just so that you make sure you don't miss some people who may have more subtle forms of it. And so every good screening test has what's called false positives, and those are patients who have a positive exam or a positive screening exam and need to be further evaluated, and that further evaluation ends up being normal or negative. And so just to give everyone an idea of what that looks like as far as mammograms, I have here this pictorial that goes over basically for every 100 women who get screening mammograms, about 90 of them, or 90%, will be told that their mammogram is either normal or what we call benign. And in those patients, that would be basically a negative exam, and something that they would just make sure to follow up with their provider and make sure that there is kind of plans to come back for mammogram the following year. So kind of that's the best case scenario. But those there'll be 10 who are called back to get further either mammogram images or ultrasound images. And of those 10, 6 of those will kind of, based on that repeat imaging and additional imaging, be told that the exams are normal, or we're able to clarify exactly what it is that we weren't sure about on that initial mammogram, and we can see that whatever it is either normal or something that we know is not something to worry about. And so the majority of the callbacks from that are going to kind of end up being in that same category. Then 2 of those would end up being kind of in a category where we would suggest getting follow-up imaging. And specifically, those are the ones where we think very, very likely these are benign things, but we can't say for sure. And so that's typically done with a follow-up exam in about 6 months. And then 2 out of those 100 patients will end up having a biopsy recommended. And so that's kind of a general breakdown of the spectrum of what can happen after a screening exam and how frequent those are. Just kind of helps me to have a sense for like where things fall as far as that. So the majority of people who end up getting called back from a screening mammogram, 8 out of 10, end up either getting follow-up or not needing any further follow-up specifically for that, and can return to routine screening. So it still, we try to be very cautious and sensitive in picking everyone up, but that means there are also going to be people who we call back who don't have anything to worry about after they get further evaluated. So now I just want to touch a bit on what it is that we're looking for on the mammograms. In particular, as Kristen touched on, there's a lot that the technologist does to try to ensure that the images that we have on your screening exam are of the best possible quality and include the similar, what we call compression and technique to the previous year, as well as including the same amount of breast tissue. And we want to make sure that we are including as much of the breast tissue as possible in the mammogram, so as to not miss areas where breast cancer could be harbored, but if we're not looking at it, we won't obviously find it. And so on rare occasions, one of the reasons that we call someone back is for specifically technical reasons. So either we didn't have great compression, or some area that we wanted to assess and wanted to make sure was included wasn't on the images that we have. And so those are typically a pretty quick kind of follow-up where we get those images that we initially wanted, we have those repeated. And then it's still technically a screening examination, so it doesn't change it to another type of exam, but it's basically completing that exam. Then there's other categories of things that we call back that are because of what we actually do see on the images. The first 2 types, which are what we call either asymmetries or focal asymmetries. Now those terms, they're kind of cryptic sounding, but basically the idea is that we see a density in the breast tissue that we can't exactly explain. And typically, if someone has previous mammograms, then it means that thing that we see is either new or wasn't seen as well on the prior ones. Typically, if we have previous mammograms to compare with, then we're able to kind of be able to see if something has changed over time. And if it hasn't, then that indicates to us that it's probably a normal thing. If it hasn't changed for years, then that reassures us. But this is kind of one general category of things that we see. It's pretty broad as far as it's a pretty common reason that we get further images, but typically when we see those things, we call someone back to get additional mammogram and possibly also ultrasound images with what we call a diagnostic examination when they come back. And the difference between a screening exam and a diagnostic exam is that a diagnostic exam is specifically to look, either there's a problem, something that you notice, a lump, pain, discharge, something that you feel and notice and want to have evaluated, or something that we see on a mammogram or a screening examination that we want to further specifically focus in on and evaluate. And so that's what makes something a diagnostic exam. And so typically, if we call anything back from a screening exam, except for this technical recall, then that would warrant getting diagnostic imaging. And so for this, typically it would be a diagnostic mammogram and sometimes an ultrasound. Another category of things that we can see on a mammogram are what we call masses, or some people will call them nodules. It's similar to what this category we call the asymmetry, but it's something that we see that's more discrete. It has borders to it, and so we can call it more specifically a nodule. The most common type of mass or nodule is what we call a cyst, or it's a benign pocket of fluid in the breast, and there are a lot of normal reasons that women develop those. Some more than others. It can make it challenging as far as mammograms and ultrasounds at being able to kind of differentiate what would be a benign or normal small pocket of fluid from something that could be a breast cancer. And so in patients who tend to develop those cysts, it can make it challenging to differentiate, and more likely that they end up being called to have further imaging to help clarify. But those are kind of by far the most common types of mass, and those are benign, and most of those would end up kind of being able to be clarified at the diagnostic imaging and be able to return to routine annual screening. And then the last major category of things that we see on mammograms are what we call calcifications. It's kind of like what you imagine with kidney stones. It's a deposit of calcium that forms kind of like a tiny little, almost like grains of sand within the breast tissue. And typically those develop in one of the two kind of parts of the breast that we talked about, either the lobules or the ducts. And depending on where they develop, they can look different ways. And so specifically, we look at the way that they look, the shapes of them, and then sometimes most importantly, how they've changed over time. If the patient has previous exams that we can compare to know which ones we can look at and say are completely normal and which ones may need further evaluation. So that's kind of the final main category of things that we can call back. And those typically are things that we see only by mammogram, and so that's the way that we further evaluate it with what we call diagnostic mammogram. Let's talk a little bit about, now shift over to the system that we use to report these things. As I mentioned before, it's we're very fortunate in the world of breast imaging that the system has been standardized over decades and actually regulated on a federal level, such that every breast institute or everywhere that does breast imaging in the US follows the same specific categorization and should use very similar verbiage as far as the way that the reports are presented. And that's what we call the system is what we call BI-RADS, or breast imaging reporting and data system. And that's the whole system that we use to create these reports. And that's what you'll see in the report that you get. And there are 7 different categories of things that you can see on your breast imaging exams. But only 3 of those things are really specific to screening examinations. The remainder of those are reserved only for diagnostic exams. So for a screening exam, all exams are reported ultimately as either normal, which is denoted as a BI-RADS 1, benign, which is clinically the same thing. It ends up being the same result as normal, but that's called BI-RADS 2, and then incomplete, which is 0. And that just means that we haven't completely evaluated the breast. And that's what we would consider something that needs further imaging in some way to help clarify things. So that's the one of those categories that we talked about in the previous slide. One of those things is the reason that something would be called a BI-RADS 0 or incomplete. Then when it comes to exams that aren't definitely normal or benign, then we have reserved those 4 remaining categories. And we'll get into that a little bit later. So I just want to kind of present a sample report to be able to kind of go over some of these things, what you might see, and be able to kind of get your eyes on exactly like what examples of what would potentially be showing up. And so here we have, for every exam, there's just kind of our standard, this is from the Women's Center, a header that has important information about, what the patient, what your name is, the person who ordered your exam, when it was done, and kind of specifics about that, where it was done. And then the remainder of the report is kind of as follows, and we'll kind of go through, at least initially, like section by section, what's included and kind of where everything ends up within this whole thing. So here we're starting with an exam which is considered that first category, BI-RADS 0 or incomplete. And this actually, I'm going to fast forward one further to kind of the most basic exam and by far the most common, which is the normal exam. And so we have here, every exam describes what it is that's being done, what the reason for it is. For screening exams, that's by default, the clinical indication is screening. But that's this portion where anything that you provide or mark down on the questionnaire before the mammogram is looked at and kind of taken into account, whether you've had prior biopsies, a family history of breast cancer, any symptoms, things like that would end up we ask specifically about on the questionnaire, and those we look specifically for before interpreting the mammogram to help kind of add context to things. And so that would potentially be added into the clinical information on any screening exam that's done. We also include all the comparisons that we use to be able to kind of see how far back we're able to look at things. And if you've had previous mammograms, then we would include the dates from those mammograms. It's useful to key in on because occasionally women will have previous mammograms from elsewhere that we don't have access to or available in our imaging system. And so if we don't have it available, then it won't be included in that list. And if you see your report and you know that you had an imaging exam that was done more recent than what was listed on this comparison, then that's something that you could check in about and kind of ask. And if that's something that we manage to get available or have uploaded into our system, then we can actually take a look at that and be able to get an even better or more kind of up-to-date interpretation. Every exam also then goes into the technique involved, and I'm not going to go into detail about it, but basically kind of the type of images that we get, and these are standardized for mammograms. And then this next section is what we call findings, and that's where we describe exactly kind of in technical terms what we see. The first part, and by law, what needs to be included in all findings is a breast density statement or category. And we'll get into exactly which ones, what those standard categories are and what the implications are of those. But in this case, we can see this is considered a category C, or what's called heterogeneously dense breasts, which is kind of in the middle of the spectrum. And then after that, kind of we go into exactly the other findings that we have. And so often that'll be broken down into per breast. So right breast and left breast, we see 2 separate headers here. And then for a normal or benign exam, often we'll just have things that are, we can say that we don't see, which are kind of reassuring. And so this is kind of the standard statement that encompasses everything that we talked about in the previous slide of what we might be able to kind of call someone back for. And so these are kind of some of the main things that we're looking for. And so here in this case, this is a normal exam. So this was what you would see for a normal exam. And then to put it all together, the impression statement kind of synthesizes all of those findings into kind of what's the takeaway from this. And so for a normal exam, you can see here no mammographic evidence of malignancy. And if there are prior comparisons, then we may say that there's no change from prior exams. And so this would be a negative exam. Every report has an assessment, which is with that BI-RADS category that we talked about. This is a BI-RADS 1, negative, and every exam also has a recommendation at the end. So the recommendation for a normal exam is always to have kind of just ongoing screening, assuming that you still kind of meet those criteria for screening. And so we, in this case, recommended annual screening mammogram in 1 year. We also kind of like to make sure that kind of as part of your breast imaging report, there's kind of an explanation of different breast densities, and also kind of the fact that if there is anything of important that we have you kind of have further evaluated, that we kind of will reach out to you to kind of be able to coordinate that in the future. So this kind of standard is kind of included in every report. And that's something that we do. It's part of that federal kind of standardization by law. So here I'm going to go now, since we kind of went over all those categories, just briefly through the second category, which is the benign category. And really, it's almost exactly the same as the prior category. The only difference is that we describe something in the findings, but whatever it is that we described, we can say based on either the way that it looks or comparisons that we have that it's something that is normal or not breast cancer. And so so in this case, we can see within findings that there's a description of calcifications. And here we say that they're stable. So it's something that hasn't changed. And so based on the comparisons that were used, it was considered normal. And so this was given an overall assessment of BI-RADS 2 or benign. And the recommendations for a benign exam are the same as for a normal exam. So just routine annual screening in 1 year. Okay, now I'll go back to BI-RADS 0, or that what we call incomplete category. And this is any screening exam where we're recommending further imaging. And so in this case, we'll kind of see here that those kind of findings will be in the findings portion of the report, and the impression portion will kind of summarize all of what's in the findings. And so here for this impression, we can see described a little what we call focal asymmetry, which is one of those categories that we had shown previously, little density in the breast. You will typically describe where it is, and then typically we'll also specify what type of imaging would be useful to further clarify things. So that's useful for the future radiologist who may be the same or maybe a different person, key them in on exactly what imaging would be warranted, and for the kind of logistic purposes, knowing what should be scheduled to have followed up. And so this is considered a BI-RADS 0 or incomplete exam, which means there needs to be additional imaging. And in this case, we had recommended additional mammographic views, followed by maybe an ultrasound, followed by sonography if indicated. And so the recommendation under here is for additional views. But we also mentioned that if prior studies can be obtained, then an addendum to that report could be made. And that could potentially prevent someone from needing to come back. So in this case, can see that there were no previous comparisons. And so if one were to know that they had previous imaging elsewhere, then if they were able to get those and kind of have them forwarded or sent to us, then that's something that we could clarify. And if we can see that something hasn't changed over some time on mammograms, then that's something that we can be more confident maybe that it's normal or benign. And so that's something that you may see occasionally on reports if you don't have previous imaging with us. Group of things that we see, and those things have been studied over the past 10, 15, 20 years that this reporting system has existed. And we can say based on all of that data that when we see those things, there's more than a 98% chance that it's a normal finding, but we can't say it's 100%. So if ever we see that, then there's a very standard follow-up routine that we do to be able to clarify it. And really what that involves is, however it is that we see that finding, we get shorter follow-up imaging to be able to show that things don't change over a course of at least 2, sometimes 3 years. And so that's the standard follow-up for that would be a 6-month follow-up. Typically at least 2 6-month follow-ups, and then additional follow-up to show that something isn't changing for 2 years. And so that's kind of another thing that one might see, but that's something that you typically will only see after a diagnostic exam. So if you're called back from a screening examination, which would have been that incomplete category from the screening exam, then this is something that one might see on their diagnostic exam when they're here. And so it's as mentioned, kind of about I'll go back to the slide that shows it. About 2 out of every 10 people who come back will have that type of result. Okay. So I wanted to get into this kind of category just to kind of give you a sense for what it is that it looks like, what a report looks like if we're recommending to have what we call a needle biopsy. And this is something also that would only happen after a diagnostic exam. So that doesn't happen after a screening examination. This is after one were to come back from a screening exam and get more images. And here, this is a pretty long report because this report is actually a combination of both an ultrasound and a mammogram. And so they're all kind of concatenated here. They're kind of put together. And so kind of the first portion of this is the mammogram. And then the second portion of this are the ultrasound kind of results. And in this case, it has all those same pertinent sections. For the mammogram part, it also includes the breast density and kind of what we see on the mammogram per each individual breast in this case, and then ultrasound. And typically, those are 2 different ways, 2 different kind of types of imaging to be able to look at things in a different way. And so they are often complementary to kind of be able to clarify exactly what it is that we're seeing. And so oftentimes, I would say that maybe even about half of the times that something is called back, it's both of those things that are used together in order to kind of get a better idea. And so anytime that we can't say that something's more than 98% sure that it's benign or normal, then the next step is always to recommend something to further clarify it. And most common thing to do that by far would be a needle biopsy. And that's something that can be done either under ultrasound guidance, if it's something that we see under ultrasound, or using a mammogram to guide us. And that's what we call a stereotactic biopsy. And so that's kind of the best way to be able to clarify something further that we can't clarify with imaging. The majority of the things that we end up biopsying are also normal and come back as benign or normal. But the only way for us to know is to get that sample of little tissue and have it looked at under the microscope in those cases. So we can see here in the impression for this, we discuss what's seen in the breast. Then we particularly, either in the impression or in the recommendations, we specifically say what it is that we, think needs to be done, whether it's an ultrasound biopsy or a stereotactic biopsy, as we talked about. And typically we'll also reach out directly to the provider who ordered the exam, so primary care provider, gynecologist, to actually communicate those recommendations, make sure that they're aware. They can follow up also with you, and make sure that we everyone is in the loop and knows what's going on. We also do quite a bit behind the scenes to try to coordinate scheduling and make sure that whatever we can do to support someone through that process to getting the biopsy done and getting the results, we do make sure to try to be very available for that. And we have specifically a nurse navigator that works really closely with us and with anyone who we recommend a biopsy for, to make sure that any questions are answered, and to make it as smooth and as least worrying as possible. And as I mentioned, most of the things that we do recommend biopsies for end up being normal or benign things that we results that we get. So sometimes some of the sometimes the biggest worry for us is the worry and anxiety that it causes, because a lot of these things end up being normal. So we definitely don't take that lightly, but we are very cautious in making sure that we can evaluate everything that could potentially be of concern. So and so these final two categories are less likely but possible outcomes from diagnostic imaging. In particular, this BI-RADS 5 category is something that would be more suggestive of breast cancer. If we see certain things, then that can suggest that. And then this final category is reserved for patients who already have known breast cancer that is either being actively treated or hasn't started treatment yet. So that's the takeaway as far as the reporting portion, what you can see in the reports when you get them. And I'd like to just open it up to any questions at all related to that. If anyone's seen something that they weren't sure what to make of, or heard anything about, things that they've, seen included in these reports, this is a chance to help clarify and demystify any of that. So I'm going to shift gears a little bit into breast density, what it is, why it matters, and what the current recommendations for it are. So based on that standardized classification system, there are 4 specific categories on a mammogram that a breast can be placed into, based on what we call density. And density really is an idea of what the proportion of this either fibrous or glandular tissue is to, or connective tissue is to, the fatty component of the breast. And so the more fat that there is within a breast, particularly interspersed within those other components, the easier it is to see if there's an abnormality that is developing or growing within there. On the flip side, that also means that the denser the breast is, or the less fat that there is within the breast, the less of an ability a mammogram has at being able to pick up something that's new. And so that has pretty significant implications, because if an exam is a lot more useful in someone who has more fat within their breast, less dense breasts, then the worry is, could we be missing some of those ones in patients who have denser breasts? And so that's why, as part of this standardization, we include exactly which category that you're in. And so the 4 categories are labeled A, B, C, and D. And here are examples going from least to most dense. The least dense is almost entirely fatty. Then we have scattered fibroglandular tissue. And then here we call it heterogeneous dense, and then there's extremely dense. And so we know that for these two more dense categories, the sensitivity of mammograms alone can be a little bit diminished, especially in this extremely dense category. And so those are the cases in which we would recommend or consider getting some other supplementary form of screening in addition to just a mammogram. And so the data on exactly what the best supplementary type of screening is for patients with dense breasts is still kind of a little bit up in the air. But practically speaking, and based on what's kind of the easiest to have obtained and to potentially add additional value, the best of those thus far is breast ultrasound. And so in those two categories, those two denser categories, those would typically warrant and for most insurance companies allow one to be entitled to having a screening breast ultrasound. The majority of people are within these middle two categories, this scattered category and this heterogeneously dense category, about 80%, but there's 10% in each of these other extremes. So the other thing to think about is that the risk of breast cancer is actually proportional to the amount of glandular tissue that there is within the breast. And so aside from these extremely dense breasts being harder to diagnose breast cancer in, it's also more likely for breast cancer to develop in denser breasts just because there's more fibrous and glandular tissue there for it to develop within. So it's kind of this double kind of disadvantage to denser breasts. And so currently the recommendation is there's not explicit recommendations as far as what the best supplementary screening exam is for dense breasts, but practically speaking, and what's kind of makes the most sense is breast ultrasound. So the last thing I wanted to touch specifically on is high risk screening, and that's kind of a specific category where perhaps one has certain things that we know they have that increase the risk of having breast cancer at some point in their life. The most common things would be family history of breast cancer. Of course, if one has themselves had breast cancer in the past, then that automatically puts them within this high risk category. And then certain other either genetic factors, if you have a known family history of certain mutations that place your family member at risk for breast cancer, and you may or may not have that, then that could put you in that category. Or if you've been exposed to things that increase your risk for cancer. So for instance, any history of radiation to the chest, for instance, in the past, then those things increase your risk down the line for having breast cancer. And so you can see within this, one of those things is dense breast tissue. It's harder to quantify exactly what the increase in that risk is from it, but it's something that's factored in. And typically we recommend that everyone at some point in their 30s has, at the very least, some sort of risk screening or risk stratification, so that you may know exactly kind of how likely you are to develop it at some point, and that can inform either what kind of screening exams to get or when to start screening. And so within the category, the ACR, the American College of Radiology, has specific recommendations on what to do to screen patients that are within this high risk category. Specifically, we recommend earlier mammography, which is kind of, instead of starting annual screening mammograms at 40, perhaps you could start at some point in the 30s or even prior to that. And it kind of all depends on the situation and discussions with the your doctor and kind of being able to assess what the risks are of getting screened earlier, such as false positives and things like that, and what the benefits could be based on, you know, what that risk is. The kind of official screening recommendations are to supplement mammograms with another form of screening for people who are at a higher risk. And the most studied thus far for high risk screening is breast MRI, actually. And despite the fact that it's kind of a longer exam, and it's something that we give, you know, IV contrast for, so it's something that we get an IV in prior to getting the exam. The sensitivity for breast MRI is high enough that we feel like it adds benefit. Though with it also does come with the risk of false positives. So that's kind of the balance that one wants to strike. But in someone who has a higher baseline risk, that's a kind of a trade-off that that as an organization, we feel the American College of Radiology felt and feels is kind of a reasonable balance. And so in any patient who has that, is getting those for high risk screening, typically the way that we'll do that is with annual mammograms, and then alternating with annual breast MRIs. So every 6 months. So mammogram, 6 months ultrasound, or 6 months MRI, and then 6 months mammogram. And that's typically kind of the way that goes. So it's kind of as an overview. There's a lot more detail that can go into that, what kind of that whole category entails. And I think the biggest takeaway here is that for anyone, it is important to kind of have some element, some type of risk assessment in general, whether that's themselves based on knowing that there's a family history, or there are certain, you know, genetic things in the family, or personal history of prior radiation, things like that, or up to kind of talking to your doctor about it and seeing if that's something that needs to be formalized to be able to kind of fall within that high risk category and get that supplementary screening. So that's kind of the last specific kind of structured thing that I wanted to touch on. But now